Good evening, good evening, good evening. It's 21:56 Central African Time on Tuesday, 14th of April 2020. We are in the midst of the COVID-19 crisis, and we continue having discussions about how the government is responding to the pandemic, how everyone is responding to the pandemic. We continue discussing different issues relating to the COVID-19 pandemic. This is All the Facts with Dr. TJ Mohale. Today I will be taking you through, we will hopefully together be going through to the SA COVID-19 epidemic trends and next step, prepared for Minister of Health, the Honorable Dr. Zweli Mkhize. This was prepared on the 13th of April 2020 by Professor Salim Abdul Karim. So we will go slide by slide. This document is 34 pages. He is the chair of the Ministerial Advisory Group on COVID-19. As you can see there, Professor Abdul Karim is the chair, he is the director of CAPRISA. CAPRISA is the Center for the AIDS Program of Research in South Africa. So he is an adjunct professor of immunology and infectious diseases, Harvard University, adjunct professor of medicine, Cornell University, vice chancellor, research, University of KZN, director, the DSI NRF Center of Excellence in HIV Prevention. So he is a well-learned professor who has done a lot of brilliant work for the country in HIV work and in other fields of research, from immunology to infectious diseases. So this presentation was given to the nation last night on the 13th of April from 8 p.m. I think until 10:30. I only managed to watch it on YouTube because I was at work. So let's hope the network have mercy on us, because I am hearing some rain, thunders, and gathering outside. So let's hope the network stays with us and we are able to engage on the SA's COVID-19 epidemic trends and next step. So we will just start slide by slide and make a few comments. And hopefully you are able to comment and we can engage on the topic. This is an open platform. Everyone is welcome to share in their opinion. All opinions are welcome. So the outline, we will look at the slides that are talking about the coronavirus. There is two parts, the coronavirus epidemic, and part 2 is the South Africa's response. So we'll just go straight to the slides. This is just the slide on the outline. So so the first slide of the topic talks about the first million cases of COVID-19. I hope South Africa never gets to 1,000,000 cases, because this is a very deadly virus, as we have seen from other countries across the world. So we don't want to see any country with 1,000,000 cases of COVID-19. That is why there are mitigating factors in place. The United States of America, we always start by looking at the Johns Hopkins website. Unfortunately today, for reasons beyond me, apologies guys, but this stand for the cell phone for the camera is giving me a few problems. I'm trying to get the stability correct so that we can have a proper engagement without any disturbances. So let's see. Sorry guys, it's just unfortunate, it's just unfortunate. Technology can be very troubling. Just bear with me for a second there. The United States of America has conducted more COVID-19 tests than any other country in the world. If you check the statistics, you will notice that unfortunately, their cases have gone above 500,000 in the United States. So it looks like they might reach 1,000,000 cases. They are having strong mitigation factors over there as well to try to contain the COVID-19 virus. So worldwide, we are just closing at 2,000,000 cases now. So we are close to more than 2,000,000 cases globally. So this is a pandemic of great proportions. This slide is talking about country-level epidemics, country-level epidemic trajectory. You see, each country is trying to do their best to get the best statistics available and to make sure that data is available to provide information. Yes, I agree, Siviwe. We will deal with that issue of per capita testing. But you can't deny that the United States has a population of more than 350 million people. I think the United States is the third largest country in the world in terms of population sizes, just behind the People's Republic of China and India. I think the United States is the third largest populated country in the world. So they are currently performing, as their president says every day, I don't know but they're performing just about more than 100,000 tests a day. They have tested more than 3 million people. So in terms of number of cumulative tests, you have to say the United States is doing very well. Of course, you want to compare that with the population, But when you have a population that is approaching 400 million people, you have to start somewhere. And the United States is putting a lot of effort into cumulative testing. With time, that testing will bear fruits for them. It will bear fruits for them. So cumulative testing, Mr. Sviwe Mabija, is very important. You cannot produce these graphs and say, I have, you see, on the y-axis is total cases since the 100th case. On the bottom here is days since. So you are comparing cumulative test on this graph. You are comparing it on time. You cannot be able to produce this graph if you are not testing people. You see here, South Africa is not there on this graph. South Africa is not there. South Africa has tested yesterday, the Minister of Health started by saying that we have tested 83,000, we have conducted 83,000 tests, both in private and in public. We are a population of 59 million people or so. Unfortunately, I don't like being the bearer of bad news, but we have only tested 0.14% of the population. I repeat, South Africa has tested 0.14% of the population. This is a very small number. This number is very small. The minister spoke about conducting 5,000 tests a day. He has also spoken about taking that number to 36,000 tests a day. Unfortunately for the minister, the problem is the cost. The current cost of the test is around 850 rands to 1,400. I've just taken the lowest number, which is 850. At the present moment, as it stands, at this moment, the available test in South Africa, which is a laboratory-based PCR test, which is time-consuming and has a lot of leg face. To get to the minister's target, we will have to spend 30.6 million rands a day on testing. Let me just repeat that again. Our minister's target, we have conducted 83,000 tests, which works out to a mere 0.14% of the population. The minister's target is to conduct at some point 36,000 tests per day. Currently, the test costs 850 rands to 1,400. I've just taken the lowest available cost, the cheapest one, 850. To get to 36,000 tests a day, we will have to spend 30.6 million rands on testing a day. That is money I don't know if Dr. Zweli Mkhize has a budget for. What does this mean? This means we need a faster and cheaper test. We need a faster and cheaper test. How is the United States conducting more than 100,000 tests a day? Over there, we will go back to the slides. We are just stuck on this slide number 4. We will go back to the slides and continue. I just need to clarify you on the issue of testing. The United States is able to test more than 100 tests, to perform more than 100,000 tests a day. The reason for that is because they have enacted the Defense Productions Act. This means private companies are actively producing everything that is needed for testing. They are actively assisting and working with public laboratories. They are working with public laboratories. They are working with universities. They are working with the CDC. There's a lot of blame in the United States about testing, but at least they're doing something. The message we are learning here is that you need to produce your own test kits. Sadly, we are not. We are unfortunately relying on India, South Korea, and China. I don't know yet if the United States has started exporting test kits to other countries. I know China is. I know India will start soon. I know we are waiting for some point of care tests. These are the ELISA tests. They can take 15 minutes. The WHO message is 3 words: test, test, test. Why? We are fighting an invisible enemy. The only way to see this enemy is by testing. So currently our testing is lagging far behind. The scientific and technology sector must become heavily involved, and they must start producing test kits locally. I am of the opinion and knowledge that we have the scientific expertise, we have the technology. If we want, we can work on producing our own test kits. Everyone is trying to buy test kits from these countries. It's a scramble. Europe is heavily hit by COVID-19. They are trying to get supplies from the same place that the 54 countries of Africa is trying to buy. So to produce these curves, for you to see the invisible enemy that is COVID-19, you need to test. We will come back to testing in the next slides. Let's continue. Post your questions and please comments on testing. I've just shown you some rudimentary mathematics. To conduct 36,000 tests, we will need to spend 30.6 million at the current cost. Science and technology must be involved. We need to produce our own ELISA test kits. We need to produce our own Gene Expert kits. This one takes 45 minutes. The current test, which costs 850, you can wait up to 5 days for results. That is too long. We will come to these 5 days when we talk about the lag period in the next slides. Let's continue. Let's go to slide number 5. Cumulative number of cases. This slide is basically showing how our cases in South Africa have increased. If you look at the slide, our graph is going up. This is important to note. This is until the 10th of April. Draw a curve there. The curve is going up. Our curve is not going down. Our curve is going up. Our curve here is going up. So trends in new cases, absolute number of cases, moving average. So this requires a little bit of some fundamental calculations.
Let's draw a timeline. You travel to a high-risk country here. Or let's just say you get exposed. We have learned that up to 80% of people are asymptomatic. You see, you are chilling at home, you are asymptomatic. This is number of days. It's time, it's going. You are asymptomatic there. You are asymptomatic there. Let's say this is day 1, and let's say this is day 14. We know that at some point you are going to become symptomatic. You are going to seek help. You might get tested. We wait for 5 days for results. You see? So this is up to 20 days. This is up to 20 days. You see, that 21 days, the incubation period plus lab test delay. You see? So I just said that the test that we are currently doing is a PCR laboratory-based test in a virology laboratory. It's cumbersome, it's time-consuming, and it's expensive. We will have to wait for some days before we get the test. You have the virus itself, due to its own nature. It has an incubation period that varies from 1 to 14 days up to 21 days. You can be asymptomatic as well, you see, for a long time before you are diagnosed or before you get tested. What does this mean? This means that every morning when we are looking at the result, at the number of cases at any given time, that might actually be an infection from up to 20 days ago. You see, when the Minister of Health comes today and say, today we have seen a number of 145 increase in our tests. This is not from today. This is not from yesterday. This is not from the day before. This might be from an infection that occurred 20 days ago or even more. If you only count the incubation period, this can be up to 26 days ago. So there is a long lag period. I'm sorry guys, there is lightning in my village. If for any reason this video is delayed or is cut, just know that there is lightning and it is about to rain. We are about to receive some pre-winter rain. So I was just saying that we are not seeing the infection in real time. We are seeing the infection from a few weeks ago. This poses challenges. That means you cannot say you are seeing the effects of any mitigation factors or any lockdown that was initiated, 19 days ago. We will see the effect of the lockdown in the near future, which even complicates things more. You see, that is a very relevant question. I will say the laboratory, they must release the results in twofold. You see, do you release the results based on the day of collection of sample? Okay? Or do you just release the results based on the day of availability of results? As I've just explained, there are a lot of factors here involved. A specimen is collected in the Bundus of Muleji has to go to Polokwane, go to Johannesburg to be tested. That takes time. So I think they can release 2 sets of results to have a better picture for academic purposes, for data analysis purposes. Let's look at the day that the specimens were collected, not just the day that the results are available and become logged onto the system. This is open for discussion. I said I don't have the answers. We are just trying to analyze. Let's look at slide number 8. So why is South Africa not on the expected COVID epidemic trajectory? This is a line of the United Kingdom. These were some of the predictions that were made. This is South Africa. I will take you back to this. I will take you back to the first rudimentary mathematics I made and say, we have not tested enough people to know exactly where we are. I will say we don't have enough data. Unfortunately, that is just my opinion. You see, we will go into some virological explanation in later slides, but I don't think we have enough data to can conclusively say if we have not conducted. The Minister of Health has repeatedly said we are conducting about 5,000 tests a day. We are unfortunately not conducting that number. The plan is to soon start testing 36,000 people a day. We are not, if we start testing 36,000 a day in a month, in a month, we will test around Hey, Unati, thank you for the question. We will come to that. If we start testing around 36,000 people a day, we will multiply that by 31. You will get just around 840,000 people. You see, this is a significant proportion of our population. Divide that by 59 million. I know you guys have calculators. So what is it? Multiply by 100. What is the percentage? In a month, if we get to testing 36,000 people, we can get to this number. We will have better data. Right now, our data is skewed. Remember the other day when we had conducted 48,000 tests, we were told that only 6,000 of these tests were from the public. The other 42,000 was from private. You see, it was from private. If you look at the 6,000, this was somewhere in March. If you look at that 6,000, it's a mere 12.5%. You see, you can multiply divided by 6,000, multiply by 100. You will get 12.5% there. You can do the maths. So, the minister has now come out and said we have done 83,000 tests. 21,000 of those tests are from the public. So, do the maths. 21,000 divided by 83,000. Guys, help me. I don't have a calculator. What is the percentage? The minister said yesterday the number of tests done in disadvantaged communities has increased. This is important to analyze. You see, we don't want a skewed view of the virus. This is an invisible enemy. The WHO has told us that the only way of seeing the enemy, guys, 21,000 divided by 83,000 multiplied by 100. What is the number there, guys? Please assist me. So the minister spent a lot of time explaining how much testing has increased in public, how much testing in disadvantaged communities has increased. But he didn't give us numbers. So it is important to break it down. How many people from Khayelitsha have been tested compared to how many people from Camps Bay have been tested? That is important. South Africa is and remain a country based on differences in socio-economic factors. We will come to that when we go through the slide further. Unat is asking, aren't we missing the third option, the actual day of testing? This is when I say day of collection of sample. You see, this is the day in which the sample is collected from the patient. You see, this is the day the results have become available. As soon as the test is conducted, the results are made available. We can add that, but this will just speak to the delay in computing and getting the results validated into the system. So that is why I'm only addressing a twofold data analysis. Let's continue. We are now on slide 9. Don't worry. We are getting there to slide number 34. Stay with me. I hope you have data. I also hope I have enough data. If the video cut, it might also be because of data, but I'll try and quickly get back online. Slide number 10. Prof spent a lot of time talking about a unique. I have just explained to you that it's not unique. We are not testing enough. So he also asked that question. Due to low or declining testing coverage, poor communities, private lab testing, all those factors need to be looked into in detail. That is why I'm saying, as the prof, as the minister, as somebody preparing this presentation for the minister, he should be giving us these answers. He should be coming with those numbers. The NICD, the NHLS, and private labs collect those data. We write the village that you come from on the lab tests. So that data should be easily available so that we can engage and analyze. Trends in cumulative private NHLS tests, I've already covered on that. We have calculated the percentage. When we had 48,000 tests done, only 12.5% were from the public. So community transmission. So whether you agree about the origin of the virus or not, that is not the topic for today. We will still have Dr. Mohale, PhD biochemistry, to discuss the proximal origins of COVID-19. What we can agree on is mode of transmission. Thank you everyone for the data offers. They say it takes a village. It will also take a village to do this. I appreciate it. Tantusi, Honorable Ntusi is asking, how are we only testing at around 10% of the daily target? So I'll come to that in a second, but I've already touched on it. But like I always said, please, if there is something that I talked about too fast and you want further clarity, ask me. Let's continue engaging. So I will come to that. We know the virus traveled via aeroplanes around the world. from one place to another, where it left and we are sure that it traveled through air travel, which is why some countries were busy with banning aeroplanes. That was the first action, travel ban. Travel ban. They started by saying high-risk countries. Remember, who do you quickly designate high-risk country while testing universally was still very low? Countries were talking about travel bans in February. The testing of the world in February was very low. So the travel ban, that means there were other countries which today are hard hit by the virus that we initially did not consider high risk countries. So community transmission. In community transmission, it is talking about the virus is now amongst us. You see, the virus is moving from person to person. So this is where the schools, the churches, the taverns, all public gatherings come in. In slide number 13, Prof was talking of the 3 waves of the SA epidemic. We were talking about this was the expected exponential growth. Apparently, this is where we are. They are saying that the curve is declining. I disagree. I repeat, we don't know this for sure. We are not testing enough to know this. If we conduct enough tests, this graph can easily start going and look like this. This was the predicted community transmission, the green one. This is apparently where we are. I don't think this is a true representation of the community transmissions. We have not tested enough. Our people are poor. They cannot afford private testing. Ntusi, you are asking about 10%. Can you see anything with 10% of your vision? Is 10%, we are testing 10% of what we want to test. If maybe we're testing around, say, 50%, we would have a different curve. It is my opinion that if we tested more than what we are currently testing, we will produce a different graph. That is my prediction. Let's just talk about a little bit about community transmission. In South Africa, we have 3 confirmed hotspots. This is KZN, this is Gauteng province, this is Limpopo, this is Northwest, this is the Northern Cape, this is the Western Cape, this is the Eastern Cape, this is Mpumalanga, and this is Free State. Okay, so this is thank you, Ntusi. You develop a lot of graphs in the finance world. So thank you for your contribution there. We can agree that we have tested 0.14% of South Africa. Let's talk about a few facts. Gauteng has the highest cases. KZN has the third highest. Western Cape has the second highest. This is number 1. This is number 2. This is number 3. Where is the biggest airport in South Africa? We said that we spoke about aeroplanes here. Where is the biggest airport? OR Tambo. The second biggest, Cape Town International Airport. Cape Town International Airport. In KZN, you have Kinshasa International Airport. So we know that COVID-19 traveled around the world by aeroplanes. It entered Gauteng through aeroplanes from high-risk countries like Italy, France, China, and others. There's Western Cape. It makes sense. These three provinces, it makes sense. The virus entered through. There are also some ports of entry. You see cruise ships in these two. You know, Eastern Cape also has some ports and cruises. Today, people are surprised at the number of cases they've seen in the Eastern Cape. Eastern Cape, I don't know if they have a laboratory to test in Eastern Cape. So what might be happening in the Eastern Cape is that testing has increased in the Eastern Cape. I had some good news that Mankweng Hospital in Limpopo has started performing testing for us. We have been sending our specimens to Gauteng. You see? So this contributes to the lag. So what happened between the 23 and the 26th of March? There was mass exodus. Mass movement. You see? There was mass movement. People moved in between these provinces. You see? That was only the 23 of March was only what? 21 days ago? Or 22 days ago, somewhere there. We don't know yet the effect of the movement that took place in South Africa after the lockdown was increased. We don't know yet what effect, what impact that movement will have on the overall picture, what it will have on these graphs. So it's too early to tell. And also, testing in each province has to increase. That is why I'm saying statistics do not show everything. They must tell us how many people have been tested in each province. You might find out that Gauteng has tested half of all the tests. They are saying we have done 83,000 tests. How do we know that Gauteng has not done 40,000 of those tests and we are getting a very skewed picture? So Mike is saying that positive cases recorded should be compared against the total numbers tested so that we can get a percentage that the number, because a number doesn't mean anything when we are comparing provinces. We need to compare percentage similarity, similarly to how we compare elections. So Mike is into mathematics and computational modeling. You can actually develop a model, Mike, and say, we have 9 provinces. We have 83,000 cases. How many cases in each province? How many positive cases per province? And you can compare all those things. You can do it for a district level. You know, if you really want to compare it, even you are right, similarly to elections. So this will be the fires that Prof was talking about. If you can test more people, break down the statistics per district, you will be able to see the virus better and the response will be better coordinated. This is what Governor Kumo calls rolling deployment. you see, of resources. If we look at the statistics and realize that Mpumalanga has performed very few tests, but they have a lot of positive cases, that will mean that we have to deploy more resources to Mpumalanga for more testing. You see, so that is a very brilliant suggestion there, Mike. This is why someone said, to understand this epidemic better, we need to put our heads together, mix biology with mathematics to have a better solution. We need all those algorithms. It's very easy for you, Mike, to write an algorithm that will tell us, that will analyze all the results very fast. When was the sputum collected? What time was it? What date was it? When was it logged on the system? What day did it arrive at the lab? When was the test done? It's very easy to write that algorithm. We just need the mathematics and the computational expertise in the same laboratory as the biologist and the epidemiologist. Let's continue with the slides. Why did SA not follow the expected epidemic curve? Well, this is what we've been saying. I cannot comment on the expected curve because I don't think the curve we are seeing is the real curve. Where is the highest risk of community transmission? Well, this is a better map of South Africa. This is a better map of South Africa, but it was just saying what I was saying. GP, 801 cases. Western Cape, 541. KZN, 412. Are we saying that the number of 24 in Limpopo is the accurate representation? How many tests have Limpopo performed? That is the question. How many tests have Northern Cape performed? That's the question. Future epidemic scenarios. What's next? So, you have been following the news that China has eased their lockdown after 49 days, more than 49 days actually. So, we don't know how long our lockdown will last. They are talking about the delayed exponential curve, which we are saying we need more data to talk about. Can SA escape the worst of the epidemic? Is exponential spread avoidable? We need more tests. We need a larger sample, definitely more than 0.14% to answer this question. Why the delay is important? Time to flatten the curve, unique component, active case finding. So, active case finding. Only South Africa has more than 28,000 community health care workers going house to house in vulnerable community for screening and testing to find cases. New, quicker diagnostics become available. Time to prepare for the medical needs. So, let's talk about this whole thing of case finding. We have said people must stay at home. That is the message. Social distancing. Social distancing. Quarantine. You see, what proof do we have? There are different numbers that you must call. You see, the message is a little bit confusing. There is a message saying, if you are symptomatic, call the number. Do not go to your doctor or to a health care facility. The reason for this is to limit the spread. So you must stay at home, call the number, they ask you questions. They ask you about the symptoms you are having, they ask you about your travel history, and then they decide from there if you need testing. Yesterday, the minister announced that they are going to go door to door. In my opinion, why are we taking the next step if we have not evaluated the first step? Are we saying people are not calling the number? Are we saying the number is not working? Are we saying that the number is not working? Because if the number is not working, we must fix that. We are saying if you test positive, you must isolate. If you can't isolate, we will take you to a facility whereby you can be isolated. You see, you can be taken to a facility that can isolate you. So why are we going door to door? You are saying people must socially distance. Doesn't door to door defeat the whole point of isolating and social distancing as in the guidelines? Where is the data to say we need door to door? Are we saying that we have tested everyone who has come forward and say, I need to be tested? Are we saying we will be able to test everyone that we identify on this so-called screening? I'm not for screening. Here is why. Screening asks you about symptoms of COVID-19. All the research that is available about the symptoms of COVID-19, headache, sore throat, cough, tiredness, shortness of breath, they are not specific to COVID-19. There are thousands of medical conditions that can cause these things. So the commonest one right now is the seasonal flu. So I think we should be sticking to the methods that we've been using of establishing a call center in every district, have a mobile team, as they already say. The MEC of Health in Limpopo was launching a mobile sample collection unit. This should be assisting with the social distancing and the isolation. When you call this number and say, I'm in village X, I have come in contact with somebody whom I think comes from a high risk area, and we come to you, we collect the sample. If you can't, I will come to that question, brilliant question. Let me just complete here. So the government is unleashing 28,000 people. How many of them have been tested? These people are going from house to house. We are saying, stay in your house, stay in your home. Don't even touch your neighbors. We are putting 28,000 people to move from house to house. It is my opinion that this is dangerous policy. I think it is dangerous policy, and I have a suggestion. Let's test a sample of these people that we are calling brave community healthcare workers. Let's protect them. If 1% of these 28,000 get COVID-19 or has COVID-19 and we don't know, and they're going from house to house, how many people do you think they can infect? I think this is a rushed policy. I think it is not in our best interest. Let's fix the cell phone numbers. We talk about working together. Let the service providers, those ones that have been charging a lot of money on data and minutes, let them assist the government in making sure that each district has a working call center that can take a high volume of calls. You see, high volumes of call. And the mobile units become more responsive. As you are saying there, screening is non-specific. Non-specific. Only testing is specific. Only testing can show us the invisible enemy. So, unfortunately, I am receiving a call of duty. I have to go and attend to work. Need to quickly walk through the rain in my umbrella. Just think about what I'm saying. Can we afford? If you have been watching the news, we are learning that prison warders are infected. Prisoners are infected. We are learning about the unfolding issues at that private hospital in Sentin, where 12 healthcare workers have tested positive. So before I go to work, I don't know what time I'll come back. It's just gone 23 hours. It's 22:53. So I don't know what time I'll come back and if I'll be able to continue today. But we are on slide number 19. We need to finish the slides. We can continue in the morning, or I'll see if I can come back. But I have a message to leave you with. We need to test a sample of all front line workers. I was talking to my friend. We need money to test a small sample of 2,000 people. These 2,000 people must include soldiers, law enforcement in full. They are in the streets. They are coming in contact with everyone. Healthcare workers, hospital workers, basically mine workers, everyone who is considered an essential worker, those people at ESCOM who are keeping the lights on, those people at the farms who are keeping the food on our table. I say, let's test a sample of them. Let's see where is the next fire going to come from. Unfortunately, I have to rush to work. Thank you for paying attention. We will continue very soon. Thank you.